faculty, Dr. Uma Shankar, and my students, Dr. Tarini Shri, Dr. Sureka, Dr. Saranya. Let us start the program.
Yeah, please go ahead, madam.
Dr. Sureka.
Yes, ma'am. Good afternoon, everyone. I'm going to present a case of 9 months old male infant from Tirupur, brought by mother whose informant is fairly reliable, came with chief complaints of cold, cough, fever for 4 days, difficulty in breathing for 2 days.
Yes.
History of presenting illness. The child was apparently normal up to 2 months of age. That time, baby developed fever, cough, difficulty in breathing in the form of suck rest, suck cycle associated with forehead sweating, was admitted in headquarters hospital and some investigations were done, and on discharge was asked to give oral medications. When baby was symptom free, the mother stopped medication, didn't go for follow-up.
Yes. Proceed.
Again at 6 months of age, was hospitalized for respiratory infection. This time, from discharge onwards, she gives oral medication till now. Also, baby has mild difficulty in on taking oral feeds, but seems to be apparently normal at rest. This illness, cough is moist, present during day and night. Fever, continuous fever, low grade for past 4 days, relieved by oral medications, not associated with chills and rigor. Difficulty in breathing is present.
Yes, next.
Difficulty in feeding, suck cycle present, forehead sweating is present at time of breastfeeding, no history of dysuria or loose stools, history of poor weight gain is present, no history of cyanotic spells. After admission, infant was started with IV and oral medications. With treatment, child got better, respiratory distress decreased, able to take breastfeeds and oral feeds.
Yes. Yes, next.
Antenatal history.
Before this, previous slide, Saranya. Yeah. So Sureka, what are the major symptomatology till now? You have a 9-month-old baby.
Yes, ma'am.
So what were the events from birth onwards? How many events were there?
Ma'am, 3 episodes till now, ma'am. 3 episodes of respiratory distress.
What are the striking symptoms during each event?
Ma'am, respiratory distress, fever, suck cycle with forehead sweating, ma'am.
So what do you mean by suck cycle?
Ma'am, the baby sucks for some time and takes rest and then again sucks, ma'am.
Okay. So this is part of the respiratory distress. So what do you think the problem is?
Ma'am, the baby is in failure, ma'am.
No. What system do you think is involved?
Cardiovascular system, ma'am.
Okay. Dr. Uma Shankar, you want to add anything?
Okay, let us proceed. We will see after
Okay. Doctor, this respiratory distress, why can't it be a cyanotic spell?
Ma'am, there is no bluish discoloration history, ma'am.
Yeah, very good. So there is. So how do you think a cyanotic spell will be presenting?
Ma'am, there will be cyanosis first, ma'am. After that, the baby will have a respiratory distress, and it is a vicious cycle going on, ma'am.
Yeah. So at the time of crying, feeding, defecation, child will develop, particularly early morning, child will develop a breathing difficulty, which will be increased which will be associated with an increased bluish discoloration. So that is characteristic of cyanotic spell. So in this child, it is very important to elicit the negative history of cyanotic spell, for which you have to elaborate to the mother. You have to ask mother all these things. Yes. And what are the equivalent of cardiac symptoms in an older child? See, this child you told respiratory distress, forehead sweating, etc. Suppose an older child, what other cardiac symptoms you will elicit?
Excess intolerance, chest pain.
Yes, good.
Poor weight gain.
Palpitations.
Palpitations, edema of legs.
Yeah, syncope, edema, oliguria. So these are the symptoms which history you will elicit in an older child. Right, proceed. Yes, next.
Antenatal history.
Yes.
Antenatal history. Age of mother at pregnancy is 27 years. Second child, interval of 4 years between pregnancies. Pregnancy confirmed after 40 days of amenorrhea by urine pregnancy test. No history of multiple pregnancies.
Yes. Next slide.
Booked and immunized. First trimester. No history of fever with rash or post-auricular lymphadenopathy. Or drug intake, nausea, vomiting. No history of exposure to radiation. Dating scan done. Second trimester. Iron and folic acid supplements taken. Quickening felt in 5th month of gestation. No history of bleeding per vaginum, headache, giddiness, blurring of vision. OGTT done. Anomaly scan done. Third trimester. Fetal movements continue to be perceived. No history of bleeding per vaginum or abdominal pain, swelling of lower limbs. Growth scan done.
Okay, so in this history or first trimester, you're asking about drug intake. What particularly drug intake you're interested in? Which you will.
Many anti-epileptic drugs like sodium valproate or phenytoin can
Okay, so
cause
what happens
congenital anomalies.
if the mother is on phenytoin? What is the problem?
Fetal hydantoin syndrome, which consists of tetralogy of Fallot, VSD or ASD can occur.
How will be the manifestation of a fetal hydantoin syndrome? Phenotypic features. Yes. How will.
Microcephaly,
Yes.
mental retardation,
Yes. Craniofacial, clefts, cardiac problem. What will be there?
VSD, ASD, tetralogy of Fallot.
Yes, yes, and also some genitourinary abnormalities. Suppose mother takes, okay, second trimester OGTT. What is the purpose of?
Infant of diabetic mother can have asymmetric hypertrophy of interventricular septum or transposition of great arteries or ventricular septal defect.
Very good. So transposition of great vessels can occur in an infant of diabetic mother.
Sureka? Sureka?
Sir,
What is the significance of mother's age, ma? Why you are asking about the mother's age at the time of conception?
sir, as the age of mother increases, increased risk of Down syndrome, sir, in baby.
Very good. Mother Down syndrome can also cause some cardiac anomalies. And as well as father's age is also important. So at the time of conception, what is the father's age also you have to ask. Okay?
Yes.
And in the antenatal history, you make sure that how many visits the mother has undergone and where she was booked and immunized, whether she was in a primary health center or with a district hospital or with a medical college hospital. That things you have to note and how many visits she has undergone. Okay?
Yes.
Okay. Okay, good.
And
Go on.
about the drug intake, suppose the third trimester, the mother is taking NSAIDs. What are the NSAIDs the mother can take? Ibuprofen.
Indomethacin.
Good. Okay. So what will happen if she takes these NSAIDs during third trimester?
Premature closure of ductus arteriosus.
Very good. Excellent. So premature closure of ductus arteriosus. Good. Yes. Next slide.
Next slide.
Yes.
Birth history. Normal full-term delivery at headquarters hospital. Cried immediately after birth. Birth weight 2.6 kilogram. Breastfed within half an hour of delivery.
Yes. Next.
Okay.
Postnatal history. No history of NICU admission. No history of bluish discoloration of skin, mucous membrane. No history of lethargy or seizures. No history of umbilical discharge. No history of delayed passage of urine or meconium. No history of yellowish discoloration of skin or sclera. Breastfeeding done 4 times a day and 2 times during night. No history of feeding difficulties in newborn period.
Sureka, when you call it as delayed passage of meconium?
Sir, more than 24 hours.
Okay, meconium is not passed within 24 hours. You call it as delayed passage of meconium. Okay, go on. Okay.
So this baby was discharged third day of birth, isn't it?
Yes, ma'am.
Yeah. Okay. Yes, proceed.
Family history. Second child, non-consanguineous marriage, no history of heart disease in family, age of mother is 27, age of father is 28, no history of contact with known case of tuberculosis. This is the pedigree chart.
Yeah, finish it. Yes. And why do you ask history of heart disease in the family? How important it is?
Ma'am, some congenital Anomalies can run in families, ma'am.
No, we are bothered about heart disease. So what is the risk of congenital heart disease in the population, general population? Any
Ma'am,
idea?
6 to 8 per thousand population.
1%. The incidence of congenital heart disease in the general population is 1%. Suppose the mother or the sibling is having congenital heart disease.
And there is a
how much,
6% increase. That's what she is saying, madam.
How much
So,
increase is the risk?
more than
Ma'am,
the general
3
population.
times. Relative risk is 3 times if either a parent or a sibling has a congenital heart disease. The relative risk is 3. That is 3 times there is more risk. Okay.
yes.
And the family history, can you tell me any single gene disorders that leading to a congenital heart disease? Like autosomal dominant, like that? Some congenital, yes, yes, autosomal dominant inheritance, recessive inheritance. Yes.
Marfan syndrome, ma'am.
Okay, and then Holt-Oram syndrome is autosomal dominant. Autosomal recessive, anything you can call, recall? Ellis Van Creveld. And X-linked, this thing is the most common, not common, it is what we commonly find is Duchenne's. Okay. Yes, next.
Immunization history. BCG, OPV, hepatitis B are given at birth. Pentavalent OPV, rotavirus vaccines, 3 doses at 6, 10 and 14 weeks. IPV, 2 doses at 6 and 14 weeks. MR not given.
Yes.
Surekha, since
Sir?
this child is having repeated respiratory infections, what other immunizations will you suggest? This is the schedule according to. Oh, very good. What is the schedule of the pneumococcal vaccine, if at all we have to give?
Sir, according to National Immunization Schedule, at 6 and 14 weeks, a pneumococcal conjugate vaccine is given, sir.
3 doses, 6, 10 and 14 weeks, along with the
But in Tamil Nadu government, we don't give it, but it is an optional vaccine of IAP, isn't it? It's not given in Tamil Nadu government doesn't give a pneumococcal. But as Dr. Umashankar has told, in a child with congenital heart disease, pneumococcal and one more vaccine. What is important?
Influenza vaccine.
Very good.
Very
So
good.
pneumococcal and influenza. So this age group, what is the dose of influenza? We give 2 doses, primary we give 2 doses at 4 weeks interval. Okay? Yes. Proceed.
Nutritional history. Exclusively breastfed till 6 months. Complementary feed started at 6 months. Before admission, baby is on breastfeeds and half idli, 2 spoons of sambar, half cup, 1/4 cup rice and 1/4 cup cow's milk, and then ragi porridge.
Okay.
Developmental history. Gross motor, able to sit without support. Fine motor, transfers objects. Social, stranger anxiety is present. Language, babbling present.
Yes. So is it normal for age? Your interpretation?
Yes, ma'am. Appropriate for age, ma'am.
Yes, child is developmentally normal. And nutritional history, what is your inference? Is it adequate or not at all adequate?
It's not adequate, ma'am.
Not
Calorie
adequate.
and protein deficit is present.
Yes.
Why it is not adequate, Surekha?
Sir, due to repeated infections and also due to success cycle and
So
more
the
energy
child
spent
is
for
not able
respiratory.
to take the feeds properly due to the distress that it encounters, isn't it? Okay. Go on. Okay. Go on.
Socioeconomic history. Education of father 10th standard. Occupation of father tailor. Income 13,000 rupees per month. Belongs to lower middle class 3 as per modified Kuppuswamy scale.
Yes. Yes. Next.
Summary. 9-month-old male boy, second born of non-consanguineous marriage, apparently normal till 2 months of age, was hospitalized for febrile illness with respiratory distress in the form of suck rest suck cycle and foregut sweating, and again at 6 months the child was admitted with similar illness, and this time third admission with a recurrent respiratory tract infection, suck rest suck cycle with foregut sweating and failure to thrive, and is immunized up to age.
Okay, Surekha, it's a nice presentation. So I congratulate on you on that. And based on your summary of the history, can it be still be a case of recurrent pneumonia that the child is getting? I am saying this child is having recurrent pneumonia. Third time the child has got pneumonia. Is it
Sir,
recurrent pneumonia? Yes.
so if it is pneumonia means there would be chest indrawing
Oh.
can be present, sir.
Oh.
Think
Oh.
and
And
so what was along with the respiratory distress, what was most striking in this child?
succus succinctal is present,
Okay.
which
So
is
that
more towards the cardiovascular system.
and second
Great.
is there
Very
was forehead sweating.
Forehead
Third
sweating,
is there was poor weight gain.
weight gain.
great. So, Surekha, the bottom line is here your succus, cycle, and forehead sweating indicates that the child is having effort intolerance. So that is the hallmark of your cardiovascular disease. Whereas in pneumonia, the child will not have that much of these things, no. So it will have repeated episodes of pneumonia. At that time, the child will have respiratory distress. But in the intervening periods, the child will be normal. And so that's the main differentiating point. But here, the child is having a succus cycle, which is continuous, which indicates, as we have indicated, even the nutritionist, the child is not able to take the feeds properly because that is the effort. So whenever this infant child puts that effort, then it develops the dyspneic. Then the child becomes dyspneic, then it takes some rest, and then again acceptable. So that indicates the child is having a effort intolerance, which is a hallmark of your cardiovascular disease. Okay,
What
you are
you're
now
going to
clear.
see now?
Yes,
You are now clear, no? Okay, okay, okay.
yes, ma'am.
System you're going to see now.
Cardiovascular system.
Yeah. Next presenter.
General
Yes.
examination. Child is awake and alert. Child is malnourished. Is pale. Dyspneic and tachypneic. No icterus. There's no generalized lymphadenopathy. There's no cyanosis and no clubbing. Head to toe examination. Head is normal. There's no facial dysmorphism. Chest precordial bulge is seen. Extremities are normal. Genitalia are normal. And there is no sign of infective endocarditis like granulation or road spots.
Doctor, what type of facial dysmorphism you expect in this child in a case of cardiovascular? What you will look for?
Sir, in case of Down syndrome, there will be mongoloid facies, and in case of Williams syndrome, there will be elfin facies.
In syndromes, you expect a facial
Dysmorphism.
And till now, what are the positive findings in this baby, 9-month-old baby?
The baby is pale and he is malnourished.
Yes, malnourished
And then there's
dyspneic and
pale, dyspneic and tachypneic.
And in the head to foot examination, any positive findings?
And precordial bulge is present.
Yes. Okay.
Did you look for cataract, doctor? If cataract is there, what is the inference that you get?
And congenital rubella syndrome, there will be cataract.
Is the triad cataract? Along with cataract, what else will be there?
Severe, it's a heart deformities like patent ectasis arteriosus.
Very good. Yes.
Very good.
PDA,
Then?
yes. Deafness.
Ma'am, deafness will be there.
Very good. Very good. Okay.
And see, this child is a 9-month-old baby, infant. Suppose an older child, what are the other external markers of cardiac disease you would look for? In general, what are the external markers of a cardiac problem? For example, rheumatic fever, what are the external markers?
And
Yes, chorea.
ma'am, Sydenham chorea.
Yes. That means when you see, you can see those things. One is chorea, yes, subcutaneous nodules, and arthritis, isn't it? These are the rheumatic fever. Suppose the cyanotic heart disease, what are the external markers?
Cyanosis will be present.
And cyanosis, and together with that?
What else will be present? The extremities.
Both will go
And
together. Cyanosis and clubbing.
Clubbing will be there in the extremities.
And then what are the markers for infective endocarditis? External markers.
Chain wave lesions,
Yes.
petechiae,
Yes.
rod spots.
Good. So rod spot, Janeway lesion, and oscular nodes. So external markers of cardiac disease.
Disease.
Yes.
So
Proceed.
we
ma'am.
get to
Madam, shall I intervene?
Yeah, sure,
Yes,
sure.
sir. Sure, sir. Sure, sir.
So you have
Please,
to
sir.
intervene.
Yeah.
Please, sir.
What's the precardial bulge? What's its significance?
So it signifies a cardiac enlargement, sir.
Cardiac means left side, right, or atrial. Which one you are mostly problem with?
So ventricular enlargement.
Probably right ventricular. Huh?
Yes, sir.
Okay. Okay. So I think you have to mention the cyanosis. I think is head to toe examination. Cyanosis there or not?
Sinus is not present, sir.
I think you didn't mention that one.
Previous slide. Previous
You
slide.
go to
So
the
in the
previous
previous
slide.
slide I mentioned, sir. General examination.
No cyanosis, she has written. sir.
Okay, right. Okay, right. Okay. So that's important. Cyanosis is very important. Huh?
Yeah.
Okay. Another thing is precardial bulge. You have to what are the conditions? You have to know that what are the conditions produce precardial bulge. Okay, right.
If at all you have to look for cyanosis, where will you look for, ma? Where will you look for cyanosis? Doctor?
So in the palms and soles, lips, oral
No,
mucosa,
cyanosis. Cyanosis,
tongue.
where will you look for? In the ear, no.
The lips and tongue.
Yeah.
Central cyanosis, where do you look for?
So for central cyanosis, sir, for central cyanosis, we look for mucosa. I mean, oral mucosa is the peripheral cyanosis.
No, we are much bothered about the central cyanosis here because
when lips
so
and
central cyanosis
tongue.
you look for in the
Oral
mucous
mucosa,
membrane.
and then you look for polycythemia in the lower eyelid, isn't it?
Okay.
No, proceed. Proceed with
Okay, proceed. Okay.
Vitals, temperature is 100 degree Fahrenheit. Heart rate is 160 per minute. It's a bounding type of pulse with normal rhythm. There's no femoral delay and pulse is felt in all peripheries. The respiratory rate is 52 per minute. Blood pressure is 80 bar 40.
You just say whether it is normal for age, whether it is the normal range or not, rather than to say the values. What is the normal respiratory rate for this age?
Sir, up to 12 months, it is 50 to, it is 30 to 40, more than 50 is tachypneic.
For this age, the child is tachypneic.
2 months,
Yes,
it is more than 60.
More than 60. 2 to 6 months, it is more than 40.
12 months on the 50 mark. 12 months man, it is more than 40.
40.
So as he was told, what is you finish it now? Finish and then tell the inference. Yes, blood pressure.
And blood pressure is 80 bar 40 millimeter of mercury in the right upper limb and 90 bar 50 millimeter of mercury in the right lower limb. Oxygen saturation in the right upper limb is 96% and the right lower limb is 96% in room temperature.
Yeah. Now you tell your inference for each of these.
And anthropometry.
No, vitals. Be in the vitals.
Go to the previous slide. You tell the inference, doctor, whether temperature is normal for this time.
Ma'am, temperature is 100 degrees Fahrenheit, which is febrile.
Right, yes.
More than 99 degrees Fahrenheit is febrile. Heart rate, ma'am, up to 160 is normal.
Okay, there is a tachycardia.
Tachycardia may be due to the fever also. So you have to account it like that. Okay, doctor? So here it's 160 is tachycardia, no? For this age.
Okay. So at birth it is 160, up to 120 it is normal in this breed.
Okay.
See, this heart rate, respiratory rate, different ages, we cannot say as just a random numbers. We should have a chart. Okay, we should have a chart in the OP, emergency room and PICU. For different ages, you have a different upper and lower limit of normal. So according to that, we have to tell our inference. Okay, so this is not a problem. What you're doing is correct. But all these things, this heart rate, respiratory rate is based on we should have a chart. From that, we should infer whether it is normal or tachycardia. Okay? Yes.
Ma'am, pulse is bounding, which could be due
to finished. Your inference you have to tell. So that child is febrile, the child has tachycardia. So So why the child has a bounding pulse? What do you understand from that?
Ma'am, it could be due to anemia or heart
Hyperdynamic circulation.
circulation.
And where you get also higher this hyperdynamic circulation? Yes.
Ma'am, in fever.
Yes.
Ma'am, anemia.
Correct. Yes.
Okay.
Fever and anemia, you get it. Tachycardia, what are the common causes?
Cardiac failure to compensate
No,
for
common causes na adeda fever.
Fever. First thing you are having fever, no? So first say fever. Okay.
Fever,
Then
anemia, when a child is crying,
fever.
even when me or you are anxious, what happens? We get a tachycardia. So these are the common causes. Then we will talk about heart failure. Yes. So respiratory rate, what do you think?
Baby's tachypneic.
Yes,
More than 50.
Blood pressure,
Ma'am, it is within normal limit.
normal or upper limit. Okay. So because there is a bounding pulse, I expect this sort of pulse pressure. And what is the normal systolic pressure difference between the upper limb and lower limb?
30 to 60 millimeters mercury.
Normal
no.
10 da. 10
Yes.
da வந்து we
10.
expect the systolic pressure difference between the upper and lower limb.
So,
And how it will be in coarctation of aorta?
then there will be a lesser pulse in lower limb.
Yes,
There
hypertension.
will be, there will be more than 10 millimeter mercury difference.
And upper limb you will have a hypertension, lower limb the BP will be low. So just to sum up your vitals, what are what's your inference? Fast, child is febrile, yes.
The baby is febrile, tachypneic,
Tachycardia,
heart rate, tachycardia,
febrile, tachycardia, bounding, hyperdynamic
Bounding
pulse,
pulses.
tachypnea, and upper limit of normal pulse pressure.
blood pressure.
Can you repeat it?
The baby is febrile, tachycardia, tachypnea, and upper limit of blood pressure is present.
Pulse pressure. Yes, next slide.
The anthropometry, the observed weight is 6 kg, which is found to be below 3rd percentile, and which is found to be low. Length is measured to be 70 centimeter, which is 25th percentile, which is normal, and weight for length is below 3rd percentile, which is low. Head circumference is measured as 44 centimeter, which is 25th percentile, which is normal. And from the above anthropometric measures, we can infer that the baby has wasting.
Okay, Doctor, what is SAM? What or who is SAM?
So severe acute malnutrition.
Define severe acute malnutrition, doctor. What is the definition? What's the definition, ma'am?
Sir, if the set score is more than -3 standard deviation.
No, WHO has given 3 criteria.
3 criteria.
Telling correctly only. That's not a problem. But what are the 3 criteria?
Edema.
Good.
Very good. Good. Then?
Wasting.
Correct. Wasting, severe wasting. As manifested by severe wasting or weight for length. Yes.
Less than -3 standard deviation.
Very good. So Z score less than -3. Yes. In older child, what will be the mid-arm circumference?
Less than 13.5 centimeter.
11.5 centimeters. Okay. So this is the WHO criteria for the severe acute malnutrition. So this child, what is what growth chart you are using, doctor?
Ma'am,
WHO reference charts. Okay, very good, very good. Okay.
How will you measure the length, doctor, this child? How will you measure the length?
Infantometer.
Okay.
What you use to measure the length? Sir is asking.
Infantometer.
Infantometer. So up to which age you can use infantometer?
Till 1 year, sir.
Yeah, good.
After 2 years.
Infantometer. More than 1 year, it's all height. Okay.
Yes.
Good. Yeah.
Yes, next.
Okay.
Examination of the cardiovascular system. Inspection. The child is dyspneic and tachypneic. Tracheal position is in the midline. The chest wall is bilaterally symmetrical. Precordial bulge is seen. Apical impulse is visible in the left fifth intercostal space lateral to the mid-clavicular line.
How can, when the precordial bulge is
Bulge is
there,
there,
can
when the
we
chest
say
wall
the
is symmetrical, you don't say.
So
Yes,
that
sir.
is not correct, doctor. That we will
Yes.
change it up. No problem. So from the inspection, anything you come to know?
Precordial bulge is present, and apical impulse is also it is more lateralized and present in the fifth intercostal space, which is a sign of cardiomegaly. Which I
Is shifted down. You
shifted
are saying.
down. Yes.
Yes, next.
Palpation. The tracheal position is confirmed by palpation. Hyperdynamic apical impulse is felt in the left fifth intercostal space lateral to the mid-clavicular line. Grade 2 parasternal heave is present. Systolic thrill is palpable in the left lower sternal border. In the pulmonary area, P2 is palpable.
Okay. So what is hyperdynamic? What do you mean by hyperdynamic apical impulse? No. Yeah, this. Yes.
It is due to high output cardiac failure. And the apical impulse will be hyperdynamic in nature.
So actually, to be physiologically
No.
speaking, hyperdynamic apical impulse means there is a left ventricular volume overload. Left ventricular volume overload. So this child, the apical impulse is shifted both down and laterally. And then what are the grades of parasternal heave? Enumerate.
There are 3 grades, ma'am. In grade 1, it is just visible, but it is not palpable. In grade 2, it is both visible and palpable, but it can be obliterated. In grade 3, it is visible and palpable, but cannot be obliterated.
So how will you look for parasternal heave?
It can be found in 2 ways, ma'am. Either the ulnar border of the palm is kept in the parasternal area, and it is a thrust. It is we look for an upward thrust of the palm, or even a pen can be used, and it is kept perpendicular to. It is kept over the chest wall, and if it is seen moving, it tells that it is present.
Now, what is the implication? What's your inference for the parasternal heave?
It indicates right ventricular hypertrophy or left atrial enlargement.
So it's an RVH, that is right ventricular hypertrophy. So and apical impulse indicates there is a left ventricular dilatation. Yes. And what is the reason for the systolic thrill?
It indicates that a murmur is present, ma'am. So which is more in a large VST, it is palpable. So it is.
No, systolic thrill don't you get in a small VST? You get it or no? You get both, small as well as large. So the systolic thrill, by that what we understand is it can occur in 2 situations. One is a large flow and second is a large pressure gradient. In a large VST, there is a large flow across the shunt. You get a thrill. And in a small VST, there's a large pressure gradient. So you're getting a thrill. So 2 situations, you get the systolic thrill. Yes. So from palpation, what all is your inference? There is a left ventricular dilatation, there is a right ventricular hypertrophy, and the thrill could be due to, is it because of flow or pressure gradient? See,
Pressure gradient.
No, Kanna,
Oh.
then there is a pressure gradient, it is a small VST. So here
Is
now
this VST small or large VST? What do you think?
you have to correlate the left ventricular enlargement, right ventricular hypertrophy, and then the systolic thrill. So you think flow is there or pressure gradient is there? It is flow. Okay, it is because of flow we are getting that. Okay, next slide.
That's why there is ventricular hypertrophy. No? That's why the ventricles have got hypertrophy. Okay, doctor, go to the previous slide. 1 minute. So you said the child is having hyperdynamic apical impulse. What are the other type of apical impulse that you can feel or palpate?
Sure, there is heaving apical impulse.
Yes.
It is seen in aortic stenosis, and a tapping type of apical impulse. It is seen in mitral stenosis.
Very good. So that are different types of apical impulse, 3 different types, which you have to palpate. Oh, okay, good. Okay, go on. Okay.
Auscultation. A grade 4/6 harsh blowing pansystolic murmur is heard in the left lower sternal border, and it is heard best with the diaphragm of the stethoscope. Systolic murmur is heard in the apical, pulmonary, and aortic areas.
It's the same systolic murmur you are saying.
Is
Okay.
and a P2 is loud in the pulmonary area. In the other areas, both the heart zones are heard normally.
And does this pansystolic murmur vary with respiration? Does it vary, this left lower sternal border? No, it doesn't vary. Okay.
Yes,
This murmur doesn't
It is
vary.
very hard to discern in an infant, madam says, but theoretically speaking, it will not vary with
Your left-sided murmurs, how does it vary with respiration? For example, can you give me a, okay, what are the other pansystolic murmurs you know of? One is?
in VSD, it is
Okay, one is VSD. Second?
mitral regurgitation.
Very good. Mitral regurgitation. Third is tricuspid regurgitation.
Yes.
So if mitral regurgitation is left-sided or right-sided?
Left-sided.
How does it vary with respiration?
It increases with
murmurs
increases with inspiration.
Expiration. Left is expiration, right side is with inspiration. Okay.
Yes, ma'am.
Okay. So from auscultation, what is your inference?
Pansystolic murmur is present, so it is of grade 4/6.
So pansystolic murmur, we told about 3 diagnoses, that is VSD, MR and PR. So which murmur is, do you think here?
VSD most probably.
It is VSD. Okay. Okay. Next.
Summary. Sorry, examination of the other systems. Abdomen, it is soft, and liver is palpable 3 cm below the right costal margin. Also, the liver is tender with a rounded border. It is soft in consistency. The liver span is 8 centimeters. Respiratory system.
Normal or increased?
It is
What's
increased.
Inference? Abdomen, what is your inference?
Hepatomegaly is present.
Okay, so
Why,
liver
doctor? Why hepatomegaly is present?
Sir, liver span is also increased here, sir. Normally for this age, it will be less than 6 centimeter, and also in below the right costal margin, it is 3 centimeters. That is also increased. Usually, it will be less than 2.
Agreed, hepatomegaly is there, but why hepatomegaly is there in this child?
Yes, sir, because in congestive cardiac failure is present, as we saw all the forehead sweating and sucrose cycle. Because of those features, it indicates congestive cardiac failure is present, sir. So that leads to hepatomegaly also.
Very good. So it is due to the congestion. It is congestive cardiac failure. Right. Very good. Okay.
What's the liver span in different ages, no?
Ma'am, at birth it is around it is about 5.5 centimeter, ma'am. Then after it increases by 0.5 centimeter every year, ma'am. So in this age, at 9 months it is 6 centimeter.
Yes.
Then it keeps increasing by 0.5 centimeter. So in adolescence, it reaches nearly 10 to 12 centimeters.
12 years, it is 9 centimeters.
Yes.
Yes. Respiratory system. Yes.
Respiratory system. Air entry is equal on both sides. Harsh vesicular breath sounds is heard on both sides, and coarse crepitations are present on both sides.
So this, what is your inference? Respiratory system.
Pneumonia type of features are seen since crepitations is.
It is a bronchopneumonia because it's bilateral. Yes.
And central nervous system is normal.
One minute. You told, I think, intracostal subcostal recession was there or not?
Sir, we didn't tell, sir.
Yeah, no, babies having intracostal on examination, respiratory system inspection lab, the baby is having intracostal recession or subcostal recession present or not?
They are present, isn't it? Both are present.
Yes.
That you should have mentioned. What Dr. Ajendran is telling is correct. We should have mentioned that. You should have mentioned
So
it.
if we are going for pneumonia, so what's the WHO criteria for pneumonia?
Sir, it is either no pneumonia or pneumonia and severe pneumonia. 3 types are there, sir.
Okay.
In no pneumonia, only cough will be present. In pneumonia, we'll have fast breathing also is present. In severe pneumonia with fast breathing, also the chest indrawing is also seen.
So three important that is triad is, one is if you are defining a pneumonia, child should have tachypnea, subcostal, intercostal recession should be there. Third one is saturation drop. Okay. If less than 94%, okay. These are the three important things you have to take. So if you are telling pneumonia, I think you have to definitely inspection, you have to tell intercostal, subcostal recession definitely will be there.
Yes.
Because you can't explain the fever otherwise.
Yes.
Okay. Right.
Yes, sir.
Yeah, please.
Yes. Summary. 9 months old male child, second born of non-consanguineous marriage, admitted with respiratory distress, febrile illness, forehead sweating, with success cycle present, and a poor weight gain with recurrent respiratory tract infections, and had 2 earlier hospital admissions for similar complaints. On examination, the child was malnourished, has dyspnea, tachypnea, and was found to be anemic and was febrile with tachycardia. Also had a laterally displaced apical impulse of grade 2 parasternal heave with systolic thrill, and also a grade 4/6 pansystolic murmur in the left lower sternal border with tender hepatomegaly, and also had bilateral coarse crepitations on examination of the respiratory system.
Yes. So what's your diagnosis?
Also you have to add that the child had a hyperdynamic pulse.
Yes,
in the
sir.
vitals. Okay.
And with the above findings, it is a case of acyanotic congenital heart disease with a left to right shunt, moderate to large ventricular septal defect, with pulmonary hypertension, with congestive cardiac failure, and bronchopneumonia, also with anemia, malnutrition, and with no signs of infective endocarditis.
You are saying this child is having a left to right shunt, doctor.
Sir,
why there is a congenital heart disease? Why do you say so?
Because here manifestation in the child had started from 2 months of age itself, ma'am.
Correct. So yes, from 2 months. Why acyanotic?
Because cyanosis was absent, so acyanotic.
No history, no cyanosis.
Yes.
And on examination also, no cyanosis and clubbing.
Yes.
So you tell Dr. Umashankar's question. Yes.
Why left to right shunt, doctor?
Sir, if it is cyanotic heart disease, that will be a right to left shunt, sir. So here, since there is no cyanosis, left to right shunt is present.
Since there is no cyanosis, the shunt should be from left to right. And
why do you say it is VST?
Here, a pansystolic murmur is present, ma'am. It is more common in.
We don't go directly to auscultation. Before that, one is symptomatology of a recurrent
respiratory tract infections, and also there was success cycle, forehead sweating, and failure to thrive in the child.
That is one thing. And then on examination?
On examination, we saw there was precordial bulge in the child with a hyperdynamic apical impulse.
VST, we have to say, okay, palpation and auscultation finding. What's the VST finding, palpation?
Hyperdynamic apical impulse was...
VST, you forget about the VST. For the palpation, you got a thrill, systolic thrill. And auscultation, you got corresponding
murmur.
Yeah, corresponding murmur. What murmur? Pansystolic murmur? In the which place?
Lower sternal border.
Now you tell the answer why it is VST. The onset of the problem, and then you have a systolic thrill and pansystolic murmur in the left lower sternal
border.
So why cardiac failure? Why moderate to large? Why can't it be small? Small VST. Now what I'm doing is for each of your finding, I'm asking you to justify. That's all.
That
Okay?
is substantial.
So why can't it be small? I'm telling it is a small VST.
Here there are also features of cardiac failure in the child, ma'am. So
in other words, small VST will be?
It will be asymptomatic.
Small VST will be asymptomatic. So why here moderate to large? Because
it is also symptomatic, also with features of cardiac failure in the child.
Yeah, very good. So that is the problem. And apart from and why do you say there is a cardiac failure? No, before that, moderate to large. So all these terminologies, how do you categorize these things? Small, moderate, like that.
It is based on the size of the defect.
How do you categorize according to size?
If it is less than 0.5 square centimeter per meter square of body surface area, it is small. And if it is from 0.5 to 1, it is moderate. And if it is more than 1 square centimeter per square meter of the body surface area, it is a large VST.
No, I think that size, the recent sizes mentioned, updated, the smallest less than 4, moderate is 4 to 6, large is more than 6 millimeters. This is the size which is according to which you tell it is small, moderate, and large. Any other classification you have? According to location, do you have any classification?
Yes, ma'am. There are 4 major types, ma'am. There is a perimembranous type. It is most common. Then muscular type of VST. Also, there are inlet and outlet types of VST. Ma'am. One is below the tricuspid valve, and other is below the pulmonary valve.
What is the other name for inlet VST?
Tricuspid, below the tricuspid valve.
Yeah, it is called AV canal VST. Another name for outlet is?
Subpulmonic.
Very good. Subpulmonic VST. Okay, so
what is Melody D. Roger? No? What is Melody D. Roger?
Small VST with small VST with pansystole normal.
Where the VST is present. Ms. Madam was talking about location, no? In Roger's disease, it is known as Melody D. Roger. Where the VST is
muscular VST.
Yes, in the muscular part. It's a small VST in the muscular part. Okay. So go on with other.
Heard the terms QP and QS?
It is blood flow in the pulmonary blood flow and systemic blood flow.
QP is, yes. So what's the normal ratio,
normally it is less than 1.5:1.
Normal is 1:1. See, normal child,
no?
what will be, both the circulation will be the equal, isn't it? So the normal QP QS is how much?
1:1.
1. So if you say 1.5:1, what do you understand by that? 1.5:5:1, it is not normal. It is an abnormal one. So what do you understand if it is 1.5:1?
It is the ratio is increased.
And pulmonary flow is more
increased.
Yes, Sureka, yes.
Moderate VST, ma'am.
Yeah, but that is the categorization. What is the physiology? What do you understand if it is 1.5:1? How much is the pulmonary blood flow?
It is increased.
more.
It is 1.5
times that of systemic flow.
Yeah, 1.5 times that of systemic. That means 50% of the left ventricular output is shunted into the right
ventricle.
Left ventricle, 50% of its output is going through the shunt to the right ventricle. So, to cope up the systemic needs, systemic circulation needs, the left ventricle has to work 2 times more. It has to work, the cardiac output should be 2 times more to meet the systemic needs. So that is why VST is called a high output state. Okay. So the meaning of the high output is because the blood is shunted this side, to cope up with that, it is increasing its contractility and the output. Yes.
Doctor, and why that newborn period? Suppose we are taking 4 to 8 weeks, no? And congestive cardiac failure is not there. Suppose we are taking large VST. Yes, Sureka?
Sir, pulmonary vascular resistance is more in newborn period, sir. Around 6 to 10 weeks, it drops down, sir.
Okay.
At that time, the shunt will be more, so congestive cardiac failure occurs at 6 to 10 weeks.
So that means flow in the shunt also increases. That's the one thing.
No, you be clear. Because of the pulmonary hypertension, the shunt is not that much active because the pressure here is more, no? So that's what Shah wants to say. Yes,
Same
right.
baby, if you're taking the same baby, they're coming after 6 months. That precardial bulge has come down. And another thing is murmur also, that sound reduced. What will signify?
Eisenmenger syndrome is.
Yeah, what happened? The shunt reversely started. Okay, that's going for Eisenmenger. What's the Eisenmenger complex syndrome?
It is a
right to left shunt.
Yeah.
That's one of you, say.
Yes,
Yeah.
yes.
Yeah, please. Yeah.
Irreversible pulmonary artery hypertension.
Yeah.
So there will be right to left shunt and cyanosis will be present.
So it's a triad actually. It's a triad. What is the components of the triad? There should be as you told, a left to right shunt will be there, and then pulmonary arterial disease is the second component, and the third component is cyanosis. So this triad is called Eisenmenger syndrome.
So don't be happy that precardial bulge has come down and murmur has come down. Okay, this is going for irreversible. Okay, that shunt. Okay, please go again. Thank you.
Yeah, Tarini, so what do you think is the hemodynamic in this particular baby? So you said it is moderate to large. So what is the hemodynamics? How is the blood flowing? Yes.
It is flow is hyperdynamic.
The blood is flowing left to right, isn't it?
Yes.
From left ventricle, the 50% is shunt, 50% or more is shunted to the right ventricle. From there, where it goes?
It goes to the pulmonary arteries and to the lungs.
Pulmonary veins. So the pulmonary, yes.
Pulmonary veins to the left atrium and then again to the left ventricle.
So the pulmonary venous pressure is increased. And then what happens? The cardiac output is increased. And after some time, the heart is not able to cope up. So the end diastolic pressure is increased. That leads to increased left atrial pressure, pulmonary venous pressure, and that will be reflected in the lungs. So lungs, you will have an interstitial edema, which leads to breathlessness. So how breathlessness occurs, it is because of this hemodynamics. So the important what you have to underline in the hemodynamics is there is increase in the left ventricular end diastolic pressure, LVEDP. So when that is increased, you get the pulmonary interstitial edema, and that leads to breathlessness. Okay, is it okay?
Yes.
Yes. Now, along with the VST, what are the problems in this child? Cardiac failure.
Cardiac failure, recurrent respiratory tract infections,
pneumonia, and then third is
malnutrition
and anemia. So these are the three major associated problems. So why do you say this child has got a cardiac failure? So what is the symptomatology here?
There is forehead sweating with sucrose cycle and failure to thrive in the child.
Very good. So the both cardiac this thing. And on examination, why do you any features of heart failure in this child?
Under hepatomegaly.
Yeah. So the CVS examination, you found features of apical impulse, showed a left ventricular volume overload, parasternal heave implies the right ventricular hypertrophy, and as Sureka has told, there is a tender hepatomegaly. So these three findings, the left ventricular dilatation, the right ventricular hypertrophy, and the tender hepatomegaly, all this contribute towards the, and of course the pulmonary interstitial edema and respiratory distress contribute to the congestive cardiac failure.
Yes.
And what is the NIHA classification of heart failure? New York. Tarini?
NYHA.
What is NYHA? New York Heart Association classification.
There are 4 grades, ma'am.
Yes, yes.
It is either the child is in grade 4, it is symptomatic at rest.
Yes.
In grade 1, even with mild exertion, it is symptomatic. Grade 2 with moderate exertion, and grade 3 with severe exertion, it is symptomatic.
So this is actually used in adolescents, okay? So adolescent assessing the heart failure, we are using this. But this baby is 9 months. So we have another one classification to categorize the heart failure. Can you tell me what is that?
Rose criteria.
Yes, yes.
Rose
Saranya is
criteria.
correct. Very good, fantastic. It is called Ross classification. Can you tell me, Saranya?
Grade 1 is asymptomatic. Grade 2 symptomatic with dyspnea on exertion and forehead sweating.
Exertion for infant, it is feeding. So you have to say mild tachypnea on breastfeeding along with sweating. Correct. Very good. Yes.
With not affecting the growth.
So that is class 2 the growth will be normal.
Yes,
See, similar to NYHA, you have to just change instead of exertion, you have to put it as feeding. And the other difference. So class 2 is mild tachypnea on feeding along with sweating, and class 3 is marked tachypnea.
And growth will be affected.
Yeah, very good. Growth failure. And what is the last one? Class 4.
And symptoms will be seen at rest.
Fantastic. So when the child is having a problem in feeding and also at rest, along with poor waking, you put it as class 4. So this particular baby, which class do you think, Taranya?
Grade 2.
3. This child falls under
growth.
Class 3 Ross classification, because this child has got a moderate distress on feeding along with sweating, and also there are signs of growth failure. So I put this child under Ross classification class 3. Yes. What's the next problem, Tarini?
Bronchopneumonia.
Yeah. So what is why this child has got bronchopneumonia?
It is mainly due to the pulmonary artery dilatation, and also due to the pulmonary venous hypertension. There is congestion in the lungs, so there is exudation of fluids and around the bronchi and the alveoli. So it leads to recurrent infections, and that develops pneumonia.
Primarily, it is due to congestion. It doesn't have anything to do with the pulmonary artery. So it is the congestion. The congestion is a very good fertile ground for your bacteria to cause the more recurrent respiratory tract infection.
Yes. Yes.
Next complication. Next finding associated. Third one is
Anemia.
Malnutrition and anemia. So what's the reason for malnutrition in this child?
Ma'am, since the child can't feed properly due to the cardiac failure, so the feed is also decreased. Also due to cardiac failure, its need is also increased. So there is imbalance between
Very
that.
good. Very good. So the intake is decreased as well as the metabolic demands of heart failure is more. And this child, what is the weight? So why, as we have discussed earlier, this child falls under severe acute malnutrition. So what's the normal range of growth? So what parameters you assess in a growth chart in a child?
Weight for age.
Yes, Saranya, yes.
Weight for age. Height for age.
In this child, length for age.
Length for age and weight for length.
Weight for length. So these three parameters you mark it. So what is the growth chart we use?
WHO growth chart.
WHO growth chart. So in this, what is the normal range? It is 2 to 98 percentile. Okay, so what's the normal range? It is 2 to 98. So below, you call it as severe wasting or severe acute malnutrition. What you have to know is the normal is between 2 and 98, and when you convert it to Z-score, the normal range is between -2 and +2. So two things you have to remember: the normal percentile and normal Z-score. So can you repeat what is the normal percentile between
2 to 98?
2 and 98. The other Z-score is
-2 to +2.
+2. Okay. Then what's the next problem, Tarini?
Anemia.
Okay. So what type of anemia this child must be having?
Microcytic hyperchromic. Nutritional anemia.
Nutritional anemia. So what's the cause of nutritional anemia?
Reduce.
What's the cause of Yes, first of all, dietary is the main problem, and anything else we can contributing to this anemia. See, normally breastfed baby will be given iron supplements from 4 months of age. This baby till 9 months has not received any iron supplements. Second, the baby has been given cow's milk. Okay, and third, the child was not started on any non-vegetarian foods like pureed meat. So these are the three problems. So in other words, normal breastfed infants or any breastfed infant, exclusively breastfed infant should be started on iron supplementation from 4 months of age. Okay, up to 1 year you can give. And you have to avoid cow's milk up to 1 year of age. Okay. So now we have finished all these main problem and associated problem. Go to the investigations. What investigations you will do?
Okay. One more thing, doctor. So you said the child is receiving some drugs. What drugs the child would have received, ma'am? You were saying that in the history the child would have received some drugs. What drugs the child would have been put on?
The diuretics.
Diuretics. For? Why?
Congestive cardiac failure.
The child should have been prescribed with this congestive cardiac failure. And in the examination, you said that the child is having parasternal heave as well as the apical impulse is shifted down and out. No? So that signifies the child is having what it signifies to you?
Cardiomegaly.
Yes. So it is having a biventriculomegaly. So both your ventricles are enlarged. That's why, as Rajendran sir has said, there is a parasternal heave due to the right ventricular enlargement. And due to your left ventricular enlargement, the apical impulse is pushed down and out. So that also you can include it in the diagnosis, a biventriculomegaly.
Yes,
Isn't it, ma'am? We can include it now, or else it is inferred. In a case of ESD, it will be there. So you can, based on your findings, you can say that the child is having a biventriculomegaly. Okay. Okay. Then we will go on with the management of the child. Okay. Go on. Okay.
Yes, investigations, read out, yes.
Investigations. And see, complete blood count is done, and hemoglobin is 9 gram percentage, and hematocrit is 30 percentage. Peripheral smear, microcytic hypochromic anemia, and MCV is 68, and red cell distribution width is 16. C-reactive protein is
MCV, doctor.
Is the hemoglobin normal for this age?
No.
So what is can you tell me the cutoff for this age?
Less than 11 gram per stage.
Very good. So according to WHO, for this age, the cutoff is 11 grams, and that corresponds to 2.5 percentile. Okay, nowadays everything is being spoken of in percentile. So this is less than 2.5 percentile. Yes.
And C-reactive protein is 8 gram percentage.
So what
Chest
type
X-ray
of
is
anemia?
done.
We didn't finish it. So there is an anemia, and what type of anemia you think? It's a
microcytic hypochromic anemia, nutritional anemia.
So it is iron deficiency.
Nutritional anemia.
Yes.
What is MCV,
Chest
doctor?
X-ray is done.
What do you mean by MCV?
It's a mean corpuscular volume. So it is the volume of RBC.
What's the normal range of MCV, you know?
Sir, 80 to 95 femtoliters.
What's the units?
Femtoliters.
Femtoliters. Okay, it is 85 to 105 femtoliters. What do you mean by this hypochromia? You are saying hypochromic microcytic anemia. What is hypochromia? Microcytic is based on your size. That is your MCV. So hypochromia, you will say?
Reduced hemoglobin, sir.
Reduced
Central pallor is increased.
Yes, the central pallor will be increased. So that is known as hypochromia. For that, you have to see the mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration. So all these findings will be there in a CBC that when you do it. No? So mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration. That also will be reduced in this case of hypochromic microcytic anemia. Okay. RTW means?
Red cell distribution width.
What is the inference in this case? The red cell distribution width is?
It is increased.
It is increased. Okay. It means it is having more morphologically abnormal RBCs. That is
anisocytosis. So that means anisocytosis is
anisocytosis. As madam says, there is some anisocytosis. So the RDW is increased. So these are all hallmarks of your iron deficiency anemia. Okay?
Yes.
Okay, good. Okay, good. Go on. Okay, go on.
Chest X-ray, cardiomegaly, and there is increased pulmonary blood flow, and there are features of bronchopneumonia. ECG is left ventricular
How will you
hypertrophy.
see increased pulmonary blood flow in X-ray chest?
So the pulmonary artery will be dilated.
What are the lines known as? Any idea? Why do you see increased pulmonary blood flow in chest X-ray?
Pulmonary vasculature will be increased.
So you will be
Pulmonary
obviously
pectoral.
seeing the pulmonary congestion. So more of these vessels will be there. And when you look at the base, you can see some curly lines, curly B lines, curly A lines. So that lines also indicate an increased pulmonary vasculature or increased pulmonary blood flow. Okay, go on.
So ECG, there is left ventricular hypertrophy.
Instead of bronchopneumonia, you say that there are some scattered opacities in both the lung fields. That will be more good, no? Then that because of that opacities, you can say it is the child is having bronchopneumonia. Okay, okay. Good. So both bilaterally it should be present for you to call it as bronchopneumonia. Okay. Okay. Okay, go on.
There is increased R wave in ECG in elites V5 and V6. In echocardiogram, there is perimembranous type of VSD of 7 millimeter size with pulmonary to systemic blood flow ratio of 2:1 and mild pulmonary artery hypertension. Urine analysis is done and it is found to be normal. Urine culture is normal and serum electrolytes are normal.
So with these investigations, what is your inference?
The baby is anemic and there is mild to moderate VSD.
The child is anemic, the child has bronchopneumonia, the child has large VSD. See, we have categorized less than 4, 4 to 6, more than 6. This child is 7 mm, so this particular echo-wise, we confirm it is a large VSD. And the parasternal heave and all that what we saw, there is a mild pulmonary artery hypertension. And to grade also we have different degrees, 30 to 50, 50 to 75, like that. Okay. Now with how do you manage this child? Sureka?
Ma'am, first we have to treat congestive cardiac failure, ma'am.
So we have to stabilize the baby first, correct? Yes.
Ma'am, and then we have to treat anemia and infections are to be treated.
So
then closure of
you're going to give antibiotics, and for nutritionally we have to correct the baby is very malnourished, so we have to give a nutritional support. About 150 kilocalories per kg. You have to increase the energy dense foods has to be given. And for anemia, we have to give ferrous sulfate supplementation. The dose is 3 milligram per kg per day has to be given for minimum 3 months. Then for the heart failure, what do you want to do?
Ma'am, surgical closure of VSD, ma'am.
Before that, we will start medically. We will try to stabilize with oral furosemide and spironolactone. And do you have to give a fluid restriction for this baby? Suppose older child, we will say only so much fluid, salt restriction. Will we say that for this baby? We don't recommend fluid restriction.
For the infants, there is no need for any fluid restriction.
And what's the definitive treatment?
Surgical closure.
Surgical closure. And so what is the indication for surgical closure in this child?
Can we wait for the VSD to close spontaneously, ma'am, for this child?
No, sir. It is a large VSD.
Very good, very good, very good. Good.
Okay.
So it will not close. As we have discussed earlier, no, if it is a muscular VSD or melody de Roger, we can wait so that it will close spontaneously when the child is not showing any signs of failure. But here the child is having a large non-restrictive VSD Whereas you find in the echo, the pulmonary blood flow is also 2 times increased more. So if you leave it without surgery, what will happen? As Rajendran sir has said, it will go on to develop
Eisenmenger syndrome.
Eisenmenger syndrome. So it will go on to develop Eisenmenger syndrome because of the increased pulmonary flow. No, it will go on to develop pulmonary hypertension. Due to that, the shunt will get reversed. So surgery as quick as possible. You have to take the child for surgery. Okay. What is the definitive
What is
surgery?
the indication, ma, for surgery in this child?
Ma'am, large VST, 2:1 blood
And
flow.
hemodynamically, the two things are important. One is it is a hemodynamically very significant VST, and second is there is no significant pulmonary artery hypertension. So number one component is hemodynamically significant. So what is the meaning of this term? There is a left ventricular dilatation. So that implies it is hemodynamically significant. And for no significant pulmonary artery hypertension, that can be measured only with echo and cardiac catheterization when your right ventricular systolic pressure is less than 50% of the left ventricular systolic pressure. So when somebody asks what is the indication, number one is it is hemodynamically significant, and number two is there is no significant pulmonary artery hypertension. Now we'll move on to the complications. One question to Sureka. What happens if a what is the history? What happens to a small VST?
Ma'am, it will spontaneously close, ma'am. Otherwise, infective endocarditis is common.
Okay, so when how long you will wait for it to close?
Ma'am, up to 5 years.
No.
2 years.
Yeah, the answer is 2 years. So suppose you find a baby with a small VST at 8 weeks of age. They are coming to immunization 45 days of age. So what will you find it is a small VST. There are no symptoms. So what will we tell the parents? What will we tell them? When will you ask them to come again?
Will advise.
Idea? So the algorithm is, suppose I find a baby at first immunization at 45 days of age. I diagnose a small VST. So what I tell the parents, you re-evaluate them at 6 months of age. Okay. If it closes, no problem. But again, murmur is there, you ask them to come at 1 year. Again, murmur is there, you ask them to come at 2 years. So what is the cutoff you expect for them to close? 2 years. So beyond 2 years, what are we going to do? Still, if the murmur is there, we ask them to come every 2 years. You tell them yearly once or every 2 years, you ask them to come. Suppose this, even in an adult, if it is persisting, what will we do? So persistent small VSDs in the adult are called as malady de Roche. Okay. Persistent small VSDs which persist into adulthood are called as malady de Roche. And here we don't do anything for this. We don't intervene for this malady de Roche. But as Sureka has told, there is risk of infective endocarditis and aortic regurgitation. So though there is a risk, it is very low. So we don't intervene for a persistent small VST. Okay, what can happen to a moderate and moderate VST? Will it close? Any idea?
No,
Moderate VST? Small, of course, it will close. We can up by 2 years. Moderate VST? Many cases the VST may close or decrease in size. And so the big percentage will close or decrease in size, but a small percentage may not close. And in the case of large VST, what happens? What about spontaneous closure?
it will not close.
Yeah, most of them, they do not close. A very small percentage may decrease in size. So this child, this particular baby has got a large VST. So, so what we are going to recommend is, are we can we wait for it to close?
No, ma'am.
Yeah. So why we cannot wait for it to close? Because it is coming under class 3 Ross classification. The child is along with tachypnea during feeding. The child has got a very poor weight gain. So if we wait, it is not rational on our part. So we have to do surgery. Suppose we don't do surgery, what will happen? Tarini?
Reversal of shunt can occur.
So how does that reversal, what happens in a reversal of shunt?
Since a large volume of blood is continuously shunted from left to right, the pulmonary, there is a stress over the pulmonary vasculature. So the vessel wall undergoes remodeling.
Which part of the pulmonary vessel is affected most? Is it arteriole or artery or venule? Which part? Arteriole. The arteriole is bearing the brunt of the attack, and in the arteriole there is a marked intimal hyperplasia that leads to the pulmonary vascular problem. Okay, yes, continue.
There is right ventricular. This leads to right ventricular hypertrophy. So the shunt is reversed from right to left, and so the child develops cyanosis, and so Eisenmenger syndrome is also developed.
Okay, how will you know clinically there is the Eisenmenger?
There is presence of clubbing and cyanosis in the child.
And in the early stages, the heart failure symptoms may be decreasing. So we cannot be happy about it because the hypoxemia will be increasing at a later date. So we cannot be happy when the heart failure is, the symptoms are decreasing.
Yes.
Okay. Out of academic interest, I will ask one question.
Can we do a VST closure when there is Eisenmenger?
No, ma'am, it is contraindicated.
Yeah, we should not do a VST closure. What about infective endocarditis in these children?
It is the most common heart disease, congenital heart disease, to be associated with infective endocarditis.
Most common, but what the latest update says is VSDs in the first 6 months post-operative period are high risk for the infective endocarditis and not otherwise. So if they are at risk only, but when you give prophylaxis, when do you give prophylaxis for these children, infective endocarditis?
In the post-operative period for first 6 months.
For 6 months. So what is the, for what procedures we give prophylaxis? Any idea? See, we give for both dental and respiratory tract. Dental procedures like tooth, not for this baby, older children, tooth extraction, dental cleaning we have to give, and in the respiratory tract we have to give for tonsillectomy, adenoidectomy. For these procedures, we have to give an infective endocarditis prophylaxis the first 6 months post-operative. And what drug we give is? Yes, Saranya is correct. So it is oral amoxicillin. We give oral amoxicillin 50 milligram per kg 60 minutes before the procedure. If not tolerating orally, you give ceftriaxone injection 1 dose 60 minutes before the procedure 50 milligram per kg. Suppose this child you have operated and post-operatively 2 months after surgery, the child is coming with fever. So what can this be endocarditis? So in other words, how does infective endocarditis manifest?
Prolonged fever with chills and rigor.
Yes.
Fatigue, malaise.
Very good.
Petechiae, arthritis.
So prolonged low-grade fever, older child will have myalgias, arthralgias, fatigue, all these things. And the heart failure and the cardiovascular, the dyspnea on exertion may be present. Okay. And what is Duke's criteria for infective endocarditis? Any idea?
Major criteria: positive blood culture and echocardiographic evidence of endocarditis, like vegetation abscess.
Very good. Yes. Minor?
Fever more than 38 degrees Celsius. Single positive blood culture. Serological evidence of infection.
Yes, so you can have 2 major or 1 major and 3 minor. Like that, we have certain thing to diagnose infective endocarditis. And anything you know about how to take blood culture for infective endocarditis, next year you may become house surgeons. How will you take blood culture for this? child, if at all you suspect an infective endocarditis, you have to take three
blood samples, ma'am, 10 ml each, half an hour interval at different sites.
Okay, 10 ml for a smaller children, less than 3 years, we can take 1 to 3 ml. And older children, you can take 5 to 7 ml. Otherwise, whatever you told is correct. You take 3 samples at different times, different sites in 24 hours. And should you take only at the time of fever or any time? You can take even when there is no fever, because bacteremia is continuous in a case of infective endocarditis. And the treatment for infective endocarditis is usually we give for 4 weeks. We don't give, like other illness, we don't give for a short duration. What the literature says is to give injection crystalline penicillin or injection ceftriaxone, we have to give for 4 weeks. Any other, so far we have discussed the complications. One is persistent small VSTs. Second, we have discussed about untreated large VSTs. Third, we have talked about infective endocarditis. Any other complication you can tell? Sureka, Tarin.
Paradoxical embolism can occur.
Okay. Aortic regurgitation can occur. Subaortic stenosis, right ventricular outlet obstruction. So these are the complications that can occur.
Can I interrupt, madam?
Yeah, sure.
Yeah, no problem. Just I want to ask, do you know what are the mechanisms of closure of EST? Madam was saying so much about closure of EST. Any mechanisms you know how EST gets closed?
Five.
Of course, this is out of academic interest. I will ask it for PG students, but since you are all brilliant, let us shed light on that thing. Any mechanisms of closure? Yes?
Sir, approximation of edges.
Yes?
Sir, approximation of edges of...
What is the natural thing happen?
What is the mechanism? Yes,
What's prolapse? What are the valves will be get prolapse?
So mitral valve.
Aortic valve will be prolapsed in subpulmonary VST.
Very good. Good. Then.
And pulmonary? Okay, tricuspid valve also. Okay, that also will get prolapse. Okay, what else? I think 6 or 7 points are there.
Yes.
Yes, growth of fibrous tissue, growth of muscle, opposition of tricuspid valve leaflet, like that. These are the 3 major mechanisms of closure.
Good.
Yes,
Yes, ma'am. Yes, but that, actually there are 5, madam. As Sir said, there is one is prolapse of this tricuspid valve tissue or prolapse of aortic valve leaflet. And another is the presence of the fibrous tissue. And another is the formation of an aneurysm. The aneurysm may form, a membranous aneurysm, which may close this EST. So these 3 are the most common mechanisms by which the closure of EST.
Anything about embryology? Tarini can tell what is the embryology of ventricular septal formation? Anybody? Sureka, Saranya?
Ma'am, from the muscular part from the floor of interventricular area, ma'am.
Very
and
good.
Membranous part from endocardial cushion.
Very good. Fantastic.
Very good. Okay.
One more.
That's the formation of your ventricular septum. So from both these parts, the septum comes. Okay, then what happens?
So 3 components, as you told: muscular septum, endocardial cushion, and then aortopulmonary septum. These 3 are the components.
The most commonest type of ESD is
perimembranous.
Yes, Dr. Rajendran, cholunga.
Yeah, Sureka, that mother is actually you are taking care. Okay, that baby. How will you counsel the mother? So these are the case. Okay, they already diagnosed. You are as a doctor. You are discussing. So mother is anxious. I think how will you counsel the mother?
Sir, if we do surgery, means it the all symptoms will be reduced.
Okay. Any of you, Saranya, Dharani? This actually this
Sir, in feeds, it should be given, short feeds should be given with continuously for the child, sir, since it is malnourished. And it should be with high calories and high protein diet should be followed for the child, so that that can be malnourishment for malnourished.
So what's the current problem a child admitted now?
Respiratory tract infection.
Okay, you have to treat the
Pneumonia.
Yeah, so child was vaccinated for pneumococcus.
No, sir.
Government, we don't give no
Yeah,
pneumococcal.
it's not given, but that
But it has to be given, sir. In fact, we can recommend influenza and pneumococcal vaccines for this stage, since the child is going to undergo surgery also.
We have to avoid the recurrent.
And give it. That's correct. Yes.
Yeah, avoid the recurrent infection. One thing. Okay, so another properly vaccinated. Nutrition part you have to take care. What else?
The regular follow.
Growth.
Yeah.
Growth dash in growth. Monitoring.
Growth chart you have to means mark the growth chart. That's a very important thing. Okay, what else? Okay, you have to advise them. Okay, so what's the present situation? You have to maintain with medications, and another thing is you have to surgical advice. Okay, so these are things you have to advise. Okay, so any of patients, I think if you are seeing any child you are seeing, you have to empathetically you have to approach. You have to inform the mother. So after 2 hours you are seeing baby. After that you have to talk to the mother. So how you have to approach? So you have to lovingly you have to tell some encouraging words. That's a very important thing. Okay.
As SAR says, the counseling is very much important, sir. That's what we also teach to the undergraduates. So as SAR says, speak empathetically to the mother and make her understand the situation, because she may be unduly worried because of a surgery, and that too the child is going to undergo a heart surgery, which is an annoying thing. But you have to say that it is a simple thing, and with the surgery, the child will improve on all the things. And as SAR says, we have to be very empathetic towards the mother. Okay. Thank you, sir. Thank you for that.
I think the new curriculum, I think they are having communication skill. No, they have to improve.
Yes, Dr. Rajendran says that talking to the parent is very, very important. And if has empathetic attitude, as he says, it's very, very important. We are always academically case abdin pakrom, but it's not like that. We have to be more of the social and affective domain we have to take care of. It's not only academically learning. The other side of the coin, we have to give more importance.
So nowadays, senior professors, they are coming that, so don't tell the case. You have to, after that, now you have to tell the child, and a loving child, a brave child, like that. No, you have to go. Don't.
Dr. Tangavel has given a WhatsApp.
Yeah, definitely, madam. Because they are all the pain and illness they're coming to us, you have to give the respectable word you have to use. Okay, you have to use the child that tell the name, this is a child. Okay, don't tell the name, that case. That's, I think you have to avoid. Okay. I think these are the things you have to give more respect to the child. That's very important, respect to the parents. Okay, that's an important thing you have to learn. Madam, any concluding remarks, madam? Yeah.
Concluding remarks, academica illa. I enjoyed this session, Dr. Rajendran. I should thank you, and I should thank you a lot. And my students were brilliant. Dr. Uma Shankar was giving a good panelist, as a co-panelist. And I thoroughly enjoyed the session, Dr. Rajendran. I'm very thankful to you. And I thank our administration and technical team who has arranged this session.
Okay.
And from my side also, I thank Dr. Rajendran sir and as well as IAP TNSC for giving me this opportunity, and as well as I'm very thankful to my HOD madam sir. And our students are brilliant. In fact, they brought out all the essence of the acyanotic congenital heart disease, and I think we have in fact covered it very comprehensively. And I think madam has prepared very much for this session, and She has shown light on
Madam
all the
is
issues.
always point to the point. I think is I am observing so many years. I think she's very very active, and I think he's a good teacher. I think no
Yes,
that I can explain. And
yes,
she's more of an emergency that patient. That's very important.
Yeah,
yes,
I was associated with Dr.
Yeah.
Rajendran
Yeah.
conferences, many conferences, PMC, Hyderabad, KMCH, and I am associated with you for a long time, Dr. Rajendran.
Yeah, I know her very well. So on behalf of IAP TNSC, I thank Dr. Sugandhi Madam and Dr. Uma Shankar. I think the students, I think they're doing it, they did very well. So they did very well. And I think even they discussed at the level of postgraduates. I think this is too much for us, for you. I think it's definitely
yes, sir.
we discussed like postgraduate. It's good. And but in exam, I think you have to learn basics. Okay, you have to tell the basics. Never miss the basics. That's very important thing.
That's true. That's true.
Okay, how will you monitor vitals? How will you check the BP? How will you measure the head circumference? Okay, how will you measure the height? These are the basic things they will ask examiners. Okay, so always be strong with the foundation. Okay, so after that you can go up. Okay, that's my request and advice also. I think on behalf of IAP TNSA, I thank one and all. And in today evening program, we are having polystatic jaundice. I think you can already on website we have displayed the player also. If you are interested, you can go and watch. That's also exam case, postgraduate case. Thank you, madam. Thank you, one and all.
Thank you, Doctor.
Thank you, sir. Thank you very much, sir.
Thank you.
Thank you very much.
Thank you.
Thank you, students. Thank you.
Thank you.
Thank you.
Thank you.